Everyone. I'm just going to do a recording of the ears, nose, and throat assessment. If I could get to the next slide. Okay, so we talked about it in lab, showed you things looking at the external ear. Your helix is out here. Your lobule, your mastoid is that bony prominence behind that I showed you also in the lab. You can see here this, even though it says external, going into the internal to the tympanic membrane. This is your middle ear, where you might see a middle ear infection. This whole external canal, this is all considered external. So some things I think will be helpful in understanding. When I use different terms, I thought I should put it in writing and help you picture things. So you would document where a lesion exists. This lesion is up here on the helix. Otitis externa, you can see this right here. And this is another example. If you look inside the ear, down the ear canal, you might see all of this. That's also an otitis externa, infection in the external ear, not down into the middle ear. Here's another. This is a hematoma or ecchymosis, or a bruising of this whole of the external ear. This is some pictures of normal eardrums or tympanic membrane, because they don't always look the same, but what you will see here is you can see underneath, you can see through it. It's clear, and you can see bony prominences under there. Here's a better picture here where you can clearly see the bones and structure through the tympanic membrane, or some call the eardrum. Otitis media, see how swollen, red, inflamed with an infection in the middle ear. Effusion, and sometimes when there's some fluid behind there, may or may not be infected, but that's an effusion. It looks kind of cloudy. And then here is when if it perforates, with this little bubble here, bursts. So understanding some of those terms and what normal should look like, you should be able to see the bony prominences, and you should get that light reflex when you shine in there. It should not be dull, like here would be dull. You wouldn't see it, and you cannot see the bony prominences, and it's not clear. Eustachian tube, mentioned that in the lab. I think I got myself confused at one point, but see here with the eustachian tube, so when you look in the ear or you put eardrops on the adult, you're going to pull up and out. With the child, it's going to be down and out. They're more risk for ear infections because the eustachian tube is so straight. And then people with sinus issues, you see if you're full in the sinus, how it's going to put pressure, or you might see an effusion in middle ear or tympanic membrane. This is just a picture for you on remembering up and out for the adult, and down, back and down for the child because of the position of the eustachian tube. Some information on hearing, how it travels through your ear, just to have a familiarity. You can have conductive hearing loss, which is a mechanical dysfunction of the external or the middle ear. You can have a sensorineural hearing loss or perceptive hearing loss, with something wrong in the inner ear or with the cranial nerve 8, cerebral cortex. It's a nerve damage, neurosensory loss or perception loss. You can also have a mixed hearing loss, which is a combination of both conductive and sensorineural in the same ear. This is something we practice in the lab, the Weber and Rhine test, to be very just familiar with what they are, how they're conducted. The Weber is the one on top of the head where you feel the vibration and sensation and hearing in both ears. The Rhine is the one where you put on the mastoid process, and when it gets dull, bring it out for air conduction. Should be longer than bone conduction. And the Weber test, it radiates. If you only hear it in one ear, you will hear it in what's called a, quote, bad ear, and then you will check for sensorineural or conduction if you can distinguish, or sometimes it's both. Equilibrium has to do with your balance. The term to understand here is vertigo. Your inner ear is constantly feeding information to your brain about your body's position. It tells, and if something's wrong in the labyrinth or it is inflamed, it gives information to the brain, and you get a staggering gait. You maybe feel like you're spinning, or that whirling sensation of everything spinning, called vertigo. Here's the slide I had on history, and I did add some history taking at the end to assist you when you do your health history. So you're going to look for clues. You're going to ask specific questions about the ear. You're watching for lip reading. You're watching their face, watching their eyes. See if they're posturing, turning their head towards you, turning their ear towards you to try to understand better. Does their face look blank, like they're not understanding you? Is their speech can give you signs of the hearing? Is it garbled? Are they able to make certain sounds? Are they monotone? Mentioned a little ago, tinnitus and vertigo are two terms that I have at the end. Tinnitus is feel a ringing, crackling, or buzzing in the ears. You will ask them, when does this occur? Is it louder at night? Are you taking any medications? Because that can be a sign of toxicity on certain medications. Vertigo is where the room is spinning around them, or they feel their head is spinning. Are they dizzy, or they lose their balance? Do they get lightheaded? Nose and sinus, when you look up in the nares, each side is your nares. So that's how you would document that they are clear. You're asking questions about discharge. They have frequent colds, upper respiratory infections. Do they get sinus pain? How often? Do they have allergies? Do they have hay fever? Are they tender, painful? Do they have headaches in this area or down in here? Ask about epistaxis, which is nosebleeds, which I have that term at the end of the slide to help you. Has there been a change in their smell? Have they ever broken their nose? Do they have trouble breathing out of one side? When you look, you will look for a deviated septum. You will simply document if it's deviating or pushing off. This is your septum. If it's going toward the right, if it's going toward the left nare. Now remember, you're looking in for your angle, so their left is your right. So just keep that in mind. Okay, mouth and throat, which we did look at in the lab. The mouth is part of your digestive system, going all the way to digestive system. Starts at your mouth, goes all the way to your rectum. So it is important about asking questions about toothaches, hoarseness, dysphagia, and I cover that again at the end of these slides to help you with it. Your soft palate, your hard palate, you're examining the lips, you're looking at their gums or the gingiva. You're looking at their tonsils and uvula like we did in the lab. You're looking for the tongue, this papilla on the tongue, those little I don't know what to call them other than papilla. You're looking at tongue movement, tongue color, looking for sores. Look here, I gave some pictures to help you. Here on the mucosa or gingiva, you see some little ulcerations. In here is candidus, or referred to as thrush. When it's in the mouth, you see the white plaquey things on the tongue. Here is multiple dental caries, broken teeth, missing teeth. I don't expect you to say which tooth it is, just that they have multiple caries, missing teeth, broken teeth, or poor dentition, or absent teeth. Here are some pictures of tonsils. This is infected tonsils, where here these tonsils are large. They're not completely obstructed. There's still space between the uvula. And here's a set of tonsils that's not as large as these. Sometimes, as you may notice in the lab, the tonsils are all the way back. They could be absent if they've had them removed. This is about a 1, 2, 3 would be touching the uvula, and these are infected, or just you would document there's a purulent drainage or coverage on the tonsils. Your uvula helps with swallowing. The soft palate, let me see, go back here. Your soft palate and your uvula work together with your nasopharynx. That's why people, if they're plugged up in the nose, they get very nasal and they may have trouble swallowing, trouble with speech, because your uvula is part of your speech. And together, the soft palate and uvula close off that nasal passage so that the food doesn't come up into the nasal passage. It goes down into your esophagus. Also helps produce with your saliva, and I said it's part of your speech pattern. That's as deep as you need to go on that. Some terms to help you. They may have used some terms, and so if you hear those terms or you see them on an exam, your cerumen is the yellow waxy material that lubricates and protects the ear canal. Your eustachian tube connects the middle ear with the nasopharynx and allows passage of air. Your helix is the superior posterior free rim of the pinna, which I showed you on the slide. Your mastoid is the bony prominence of the skull just behind the ear, which we palpated that in the lab. Otalgia is the term for ear pain. Otitis externa is inflammation of the outer ear and ear canal. Otitis media is inflammation of the middle ear and tympanic membrane. Otorrhea is a discharge from the ear, which you saw in one of those pictures with that crust in there. Pinna is the auricle or the outer ear. Tinnitus is ringing in the ears. And your tympanic membrane, often referred to as your eardrum, is that oval membrane that you saw that's covering the middle ear, separating it from the outer ear. And vertigo is a spinning or twirling sensation. Some terms for your mouth. May mention some as we're going through the slides. Your aphthous ulcer may be called canker sores, or small, painful, round ulcers in the oral mucosa. Usually no known cause for them. Buccal is your cheek, so your mucous membranes are your gums, and on the sides of your cheek are your buccal. Candidiasis is that white, cheesy, curd-like patches on the buccal mucosa. So, that's on your cheeks. It can be on your tongue. It can be on your gums. Caries are decay in the teeth. Epistaxis is a nosebleed, usually coming from the anterior septum. Gingivitis is red, swollen gum margins that bleed easily. Herpes simplex are cold sores or clear vesicles with a red base. I didn't give you pictures of those. They can form into pustules. Leukoplakia is chalky white, thick raised patch on the sides of the tongue. Usually that is precancerous. Parotid glands is a pair of salivary glands in the cheeks in front of the ears. Plaque is a soft, whitish debris on the teeth. Thrush is oral candidus in the newborn, but I've heard it called thrush at other ages too. Uvula is the free projection hanging down from the middle of the soft palate. So when you're doing your history, I gave you questions here to remember to think about. You may take notes on these or print off the slide for when you actually do your health history, which will make more sense. I will talk about that in class. So earache, ear pain, ear infections, discharge from ears, hearing loss. If they use a hearing aid, exposure to loud noises presently in the past, work, home, recreation, ringing, buzzing in the ear, feeling, spinning, vertigo, and how do you clean your ears. Your health history for your nose and mouth, are all listed here. Your nasal discharge, unusual or frequent cold sores, any sinus pain or sinusitis, frequency of that, any trauma, injury to the nose, present, past. Do they get nosebleeds? How often do they get nosebleeds? How profuse is it? How much blood? Do they have allergies or hay fever? Or they get allergy shots? Do they see an allergist? Have they had allergy testing? How significant does that impair with their life? Have they had recent changes in their smell or in their taste? Do they have sores in their mouth or tongue? Do the sores come and go? Do they have a sore throat? Does this come frequently? Do they have bleeding of their gums? Do they get toothaches? Are they hoarse? Or is their voice changing? Does this come and go? When does it occur? Are they having difficulty swallowing? I already said changes in sense of taste. And then ask them about their dental care history. Okay, and that is the end of this lecture. Thank you.